series of classes that we are covering as a part of our crash course for all of your exams. And we at Oracle offer you live classes, recorded sessions, notes, and MCQs. In live classes, these are very helpful to keep you on track, and these 1 or 2 hours that you spend every day will definitely help you to stay on track. And recorded classes are always available in case you did not understand anything in the live classes or you want to learn more about it. And notes are as per the CBME curriculum, which are one-stop solution to all your doubts. And of course, you have plenty of MCQs to practice for your upcoming NEET or next examinations that we are having. And the best of all is a personalized counseling session wherein you will be given a mentor with whom you can share all your concerns, academic and otherwise. You can talk to them. You can if you have anything that is going on vis-a-vis your academics, or you're feeling overwhelmed with your exams and you don't know what to study, anything and everything, you can share it with a mentor, and they'll help you to identify your strengths and your weaknesses, and they'll give you a proper study plan and how to go about the examinations. And we offer these 3 different plans. In basic plan, you're going to be having the pre-recorded classes and live sessions and quick revision examination modules. But in standard plan, you'll also get live doubt clarification sessions, which are I think is very important. And in the premium plan, you'll also get one-on-one personalized guidance along with notes, live classes, pre-recorded sessions, and quick revision examination module and everything. And you can, of course, use my code Dr. Sushma 20 for any discounts on your subscription on any of these premium plans. And this is the schedule we have. And in the tomorrow's class, we'll be covering with, we'll be done with shoulder joint and other joints. And then the next 2 sessions will be like a rapid revision of all the things that we have done already, and anything other than whatever that is left out and it is not being covered in these classes will be dealt with. And I'll also help you to crack your practical examinations, how to answer question in viva, and how to write, how to approach a question, theory as well as practical. And all of these classes will be covered in the revision 1 and revision 2 classes. Do not miss them. You will be benefited plenty, because I'll be teaching you how to approach a question in theory and how to write in exams. Okay. Yes. So with that introduction, we will begin today's class, and the topic is cubital fossa. Yeah. So cubital fossa is a triangular depression on the anterior aspect of elbow. It is something that you can see for yourself. The kind of depression that we have on the anterior aspect of elbow is called as cubital fossa. Why is it called fossa? Because it is a depression. Fossa meaning depression, right? Now, what are the boundaries of cubital fossa? Cubital fossa is actually a very important theory question. Cubital fossa is a very important theory question, as well as this is very important spotter in your practical examinations, where you will be asked to pinpoint the boundaries and tell the contents. That's it. This class is a very straightforward, simple class, nothing to really bother. So in the cubital fossa, the lateral boundary is made by the medial border of brachioradialis muscle. Laterally, it is bounded by the medial border of the brachioradialis. Medially, it is bounded by the lateral border of pronator teres. The base, imagine it's like this, right? It's like a cube in which the lateral boundary is made of the medial border of brachioradialis. Medially, we have the lateral border of the pronator teres, and the base, right? If you touch it, what you're touching is the cubital fossa, and the base is made of the imaginary line drawn between the 2 epicondyles, and apex is the meeting point of the lateral and medial boundaries, that is the pronator teres and brachioradialis muscles. Simple. Whenever they ask a question on cubital fossa, suppose you get a question on cubital fossa, the opening statement is, what is cubital fossa? It is just a triangular depression in the anterior aspect of elbow. Sorted. Then come to the boundaries. Boundaries: lateral, medial, base, and apex. Laterally, what do we have? Medial border of brachioradialis. Medially, we have lateral border of pronator teres. Base is imaginary line drawn between the two epicondyles, and apex is the meeting point of the pronator teres and the brachioradialis. Simple. Next, this is the diagram that you will have to write. Okay, you don't have to write the bones and everything. Just make this small triangle like this, in which this is the brachioradialis muscle and this is the pronator teres muscle. The base is the line joining the two epicondyles, and this is a small diagram, line diagram you can make over here in the answer. Okay, just a second, guys. I'll keep this for charging. Yeah. Sorry. Next, what are the other boundaries? The first one is the roof, right? If you go on stripping the structures, you will reach the base. Now, what are the different structures that are there? In the roof, from superficial to deep, what do we have? First, we have skin. Second, we have the superficial fascia. In the superficial fascia, we have the following structures present. Laterally, we have the cephalic vein and the lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm. Medially, we have the basilic vein and the anterior and posterior divisions of the medial cutaneous nerve of forearm. Medial cutaneous nerve of forearm. In the middle, we have a very important vein, which is the cubital vein, median cubital vein and median vein of forearm. This is a very, very important point over here, guys, because this has got a lot of clinical importance to us. Okay. In the roof, what do we have? From superficial to deep, you will have to write roof. First, you have the skin, then you have the superficial fascia. In the superficial fascia, what are the different things that we have? Laterally, we have the cephalic vein and the lateral cutaneous nerve of forearm, nothing difficult. Medially, we have the basilic vein and the anterior and posterior divisions of the medial cutaneous nerve of forearm, nothing confusing. Between them, between the cephalic vein and the basilic vein, we have the median cubital vein. Medial cubital vein, which is extremely important for us to know. Look at it, guys. Look at it. This is what I was talking about. This is the cephalic vein. This is the basilic vein. Connecting them is the medial cubital vein. If you don't remember the lateral cutaneous nerve of forearm and the medial cutaneous nerve of forearm, it's still okay. It still doesn't matter, but you cannot afford to get this wrong. The veins that we have over here, that is the cephalic vein and the basilic vein, these two veins are extremely, extremely important for us. Okay, this is very extremely important for us, and especially the medial cubital vein. Then in the deep fascia, so we had skin first, we removed skin, then we had superficial fascia. In the superficial fascia, we had these three important veins. Then in the deep fascia, beneath the superficial fascia, we have the deep fascia, which is nothing but a special thickening of the bicipital aponeurosis. Deep fascia is nothing but a special thickening of the bicipital aponeurosis, right? And in the floor, it is formed by two muscles, brachialis and supinator. Brachialis and supinator. Now you have to tell me, supinator is supplied by which nerve? Pronator teres is supplied by which nerve? And biceps brachii is supplied by which nerve? We've already done this. We've already covered this. You will answer these questions. Between the two heads of pronator teres, which is that nerve that passes through and is, prone for compression, it is susceptible for compression. First question, you will tell me the nerve supply of pronator teres. Second question, you will tell me the nerve supply of biceps. Third question, you will tell me the nerve supply of supinator. Okay, all three questions are very, very important and they can be asked. Right now, this is all about the boundaries of the cubital fossa. So when you are asked the boundaries of cubital fossa, first you will write about the lateral, medial, base and apex. Then you start writing about the skin, superficial fascia and deep fascia. and you will write these two diagrams. First diagram was the line diagram and second diagram is this diagram of these veins. Okay. Then after this, we have to know about the contents. After this, we have to know about the contents. What are the contents of cubital fossa? This in itself is a 3-mark question, or it can be asked in your practical examinations, right? From medial to lateral, if you see, the mnemonic is MBBR. Mnemonic is MBBR. M is median nerve. B is the termination of brachial artery and the beginning of the radial and ulnar arteries. B is the bicipital aponeurosis, which in itself is the deep fascia, and R is the radial nerve. So these are the contents of cubital fossa, wherein the most medial structure is the median nerve. Then we have the brachial artery and the beginning of the radial and ulnar arteries. Then we have bicipital aponeurosis, and then we have the radial nerve. Right. So this is the cubital fossa. As you can see, the contents in this picture. This is the median nerve. Then we have the brachial artery. You can see it is bifurcating into radial and ulnar arteries. Then we have this aponeurosis, tendon of biceps brachii. You will tell me the nerve supply of biceps brachii. And second question, continuation. The functions, the actions of biceps. What actions does this biceps muscle do? I've already taught this many times yesterday in brachial plexus class as well. We covered this. And then we have the lateral most content is the radial nerve. Radial nerve is a superficial branch of the radial nerve. Very important question, guys, where we have covered the boundaries and now we have covered the contents. Again, memorize them in the same order. Okay, you have to memorize the contents in the same order. MBBR, M for median nerve, and termination of brachial artery, and then the origin of beginning of radial and ulnar arteries, bicipital aponeurosis and radial nerve. Okay, yes, that's it about cubital fossa, guys. And here we have to know about the applied anatomy, which I'll be teaching in the end along with other applied anatomies. But for now, if you're asked a question on cubital fossa, write about the boundaries, write about the contents, make these simple line diagrams, 3-4 diagrams, very easy, simple line diagrams you can make, and you will be given full marks, I would say. If you know this much, it is good enough for cubital fossa. And of course, applied anatomy, which I'll teach you in the end. Then we have brachial artery, right? Brachial artery is a major blood vessel of the upper arm, correct? What is brachium? Brachium means my arm, right? The artery of the arm is called as brachial artery. It is the continuation of the axillary artery beyond the lower margin of the teres major muscle. This is very important, guys. What is brachial artery? Brachial artery is a continuation of the axillary artery. From where? From which point do we call axial artery the brachial artery? Right? It is nothing but a continuation of axillary artery. I could have called it axillary artery only. But why do I not call? Because once it enters arm, we call it brachial artery. It's as simple. It's just nomenclature, guys. Any artery is just nomenclature, right? So it is a continuation of axillary artery beyond the lower margin of the teres major muscle. Guys, remember, it's not teres minor. It is teres major muscle. Again, question for you. We have covered this in osteology. Attachment of teres major muscle. Where is the teres major muscle coming from and where is it getting attached, right? I'll give you a small hint. Lady between two majors. Now you tell me where it's getting attached. Okay, next. It continues down the ventral surface of the arm until it reaches the cubital fossa at the elbow. In the cubital fossa, it is one of the contents. From the cubital fossa, it bifurcates into radial and ulnar arteries, right? So brachial artery continues down on the ventral surface, not the dorsal. It is in the anterior aspect until it reaches the cubital fossa at the elbow. Then it then divides into radial and ulnar arteries. Sorry. It then divides into radial and ulnar arteries which run down the forearm. And there's no point in guessing which are the arteries of forearm, radial and ulnar arteries. Then pulse of the brachial artery is palpable on the anterior aspect of the elbow, that is in the cubital fossa, medial to the tendon of the biceps, and with the use of a stethoscope and the BP cuff, It is often used to measure the blood pressure. Very, very important point, guys. See, you would have done BP measurement in your physiology. How do you do this? You tie a cuff and then you hear it using a you with the use of a stethoscope. You will hear the sounds, right? You will hear the disappearance of the cough sounds, isn't it? So this is how we measure blood pressure. So why do we use brachial artery? We could have chosen ulnar artery also. We could have chosen axillary artery also. Why do we use ulnar artery? Because number one, it is superficial and it is easily palpable on the anterior aspect in the cubital fossa, isn't it? If the artery is situated deeper, like if you have muscles and some other structures over it, will you be able to hear it? Will you be able to palpate it? Of course not. So brachial artery, number one point, it is palpable and it is easy to access, right? It is easy to access with the use of a stethoscope and a blood pressure cuff. I can easily measure the BP by using this brachial artery. And where is it situated? It is situated medial to the tendon of biceps, isn't it? MBBR, B. After the medial nerve, what do we have? B. B is the brachial artery, and then we have the biceps. So the pulse of the brachial artery is palpable on the anterior aspect. That is why it is used to measure the blood pressure. Okay, that is used to measure the blood pressure. Of course, you can measure the blood pressure by different ways also. Like for example, there's something called as pulmonary artery catheterization, where you can directly go and then you can directly go and measure the pressure in the left atrium, right? So there are different ways in which you can measure blood pressure, but this is a very non-invasive simple technique that we use in regular clinical practice to measure the blood pressure. Okay, another homework for you, just you will have to tell me what normal systolic blood pressure is, what is normal diastolic blood pressure. Systolic blood pressure represents what, diastolic blood pressure represents what, and normal range. Okay, and the basic definition of blood pressure, which most of us get it wrong. Okay, the very understanding of blood pressure is extremely important. Another homework for you guys. Yes, then brachial artery gives rise to following branches. Two branches we've already studied. One is the ulnar and radial artery. Radial artery is a terminal branch. Superior ulnar collateral artery and inferior ulnar collateral artery is also given by this. And of course, the profunda brachii artery, which is a deep branch of brachial artery. So, four branches are there for brachial artery: profunda brachii, superior ulnar collateral, inferior ulnar collateral, and radial. So, brachial artery is a continuation of the axillary artery at the lower border of the what muscle? Teres major muscle, continues in the anterior aspect of the arm, enters the cubital fossa, divides into radial and ulnar arteries, and it also gives rise to these four important branches. And next point would be how it is used to measure the blood pressure, right? And there are, of course, it gives ulnar artery, which is also a terminal branch, and a nutrient branches to the humerus. Not very important. Okay. But the most important aspect that we need to know over here is it also gives rise to important anastomotic networks of the elbow and the shoulder. Okay, it helps in the elbow anastomosis and the anastomosis around the shoulder joint, which is very important. Now, this is a very simple, easy diagram, guys. Look at it. This is the brachial artery that is entering into the cubital fossa, and the median nerve crosses it, right? If you remember the first class, I had taught you about how the median nerve crosses the brachial artery. Then it has given off a profunda brachii artery. You can see the deep branch which is coming like this, and some collaterals which will help in the anastomosis around the elbow. Some collaterals help in the anastomosis around the elbow, and it bifurcates as radial and ulnar arteries. Yes. Next, the continuation of the brachial artery are radial artery and ulnar artery. Radial artery is mainly posterior. Both radial artery and radial nerve, actually, they supply the posterior aspect of the forearm, right? Radial artery supplies the posterolateral aspect of the forearm. It contributes to the anastomotic network surrounding the elbow joint and the carpal bones. Okay. Next, very, very important point, guys. The radial pulse is palpated in the distal forearm immediately lateral to the prominent tendon of the flexor carpi radialis muscle. This is how we palpate for radial pulse, right? Always remember, guys, where do you palpate for radial pulse? It is always where the thumb is. Okay, don't get confused. I know right now we all answer these questions. Okay, right now if I ask you any question about radial artery, you will tell me it's a branch of brachial artery. It starts in cubital fossa, goes posterolateral. All of this is fine, but when you are put under pressure in examination, we tend to make silly mistakes. If they ask you to palpate for radial pulse, do not think of whether it is medial, lateral. Do not think anything. Just know where the thumb is. That is where the radial artery is. This is where the thumb is, and you will palpate here for radial artery. Okay, and it's a very crude way of teaching, but then this will really help in examinations. Okay, when you're standing in practical examination and the examiner is just throwing questions one after the other, one after the other, and if you don't know the first three questions, you're already so nervous, and you don't know the first three questions, you don't know what the next question is. Suddenly the examiner asks you palpate for radial artery. By chance, if you go for medial aspect and you start palpating here in this medial aspect, then it's a very bad situation. So radial pulse is always palpated where the thumb is, which is the lateral aspect. And where exactly it is lateral to the tendon of flexor carpi radialis muscle. Okay, applied aspect of radial artery is very, very important. And as you go into your internship, you do something called as arterial blood gas analysis, which is called ABG. Okay, and there will be huge fight among interns to do ABG, because you actually draw the blood from the radial artery. Okay, you puncture the radial artery and you draw blood. So radial artery, we do use radial artery for arterial blood gas analysis for ABG, mainly because of its superficial in nature. It is very superficial, and you palpate for the artery and you find where the artery is most superficial, and then you puncture it for arterial blood gas analysis. Okay, then ulnar artery supplies the anteromedial aspect. If radial takes care of posterolateral, ulnar takes care of anteromedial aspect of the forearm. It contributes to, again, anastomotic network surrounding the elbow joint. So this is a brachial artery giving rise to these two ulnar and radial arteries, and you can see how it takes place in the anastomotic joints. Then next concept is the palmar arches, which again is an important theory topic. Not so important for your practical examinations, but it's important for your for your theory examination. The superficial palmar arch, we have two palmar arches, superficial and deep. Okay. Right now I'm talking about superficial palmar arch. Superficial palmar arch is predominantly formed by the ulnar artery with the contribution from the superficial palmar branch of the radial artery. Everything is superficial here in the superficial branch. The arch passes and across the palm in a curve with its convexity downwards, right? And the superficial palmar arch extends more distally than the deep palmar arch. That is, superficial goes more distal, right? We have deep palmar arch somewhere here, but superficial is even more distal. Okay. The connection between the superficial and deep palmar arches is an example of an anastomosis, and it is tested using Allen's test. It is tested using the Allen's test. See, guys, you can see this is the superficial palmar arch, which has gone more distal as compared to the deep palmar arch. Okay, and we have connections between the superficial and palmar arches, and this connection is tested by a test known as Allen's test. Okay, I mentioned about arterial blood gas analysis. What am I exactly doing? What I'm doing is I'm puncturing the radial artery. Okay, I'll tell you about the Allen's test later, but then let me just finish off the superficial arch, and then I'll talk about the Allen's test, which is very interesting, right? Then there are three palmar digital arteries that arise from the arch, and they proceed and then they end up supplying the second, third, and the fourth lumbrical muscles. Okay, basically you can see in this diagram the superficial artery is supplying this is the first lumbrical, second, third, and fourth. It is supplying the second, third, and fourth lumbricals, which are the common palmar digital arteries, right? and they each receive a contribution from the palmar metacarpal artery as well. Next, near the level of the MCP, each common palmar digital artery divides into two proper palmar digital arteries, right? Then the four digital branches arise from this palmar arch. They end up supplying the medial 3.5 fingers. Medial 3.5 fingers. Then we have deep palmar arch. Okay. Deep palmar arch, again, it is more proximal. Look at it. Deep palmar arch is more proximal, superficial palmar arches more distal. They give rise to this common palmar digital arteries, which then give rise to proper palmar digital arteries. Okay, simple, and they end up supplying the lumbricals here. And there is an anastomotic network between superficial and deep palmar arch, which is tested by my Allen's test. Then this modified Allen test is very, very important, guys, and it is very interesting also. There is a reason why we do this. What do we do in modified Allen test is, one hand is examined at a time and the other hand is elevated, and the patient is asked to clench their fist for about 30 seconds. Okay. Then pressure is applied over the ulnar and radial arteries. So I occlude both the arteries. Then I ask the patient to open his hands. What happens? I am blocking my both radial and ulnar arteries. So I'm cutting off blood supply to the hand, and my hand should actually appear blanched. Okay. Then my hand should completely appear blanched. Why? Because I've put pressure over both my ulnar and radial arteries. I've occluded both, as a result of which the blood supply is reduced to the palm and it should look white. Then what I do, I gradually release the ulnar pressure, but I still maintain the radial pressure. Okay, I still maintain the radial pressure, but now I told you that there is a network between the superficial and the deep branch, deep palmar arches. Even when I am I'm holding radial artery, but I'm releasing pressure of the ulnar artery. Then what should happen? Some blood should enter superficial palmar branch, which should eventually seep into the deep palmar arch, as a result of which the color of the hand should return in 5 to 15 seconds. What does it indicate? It means that the arch is payment, because you see, I'm still occluding the radial artery. I haven't lifted off pressure from the radial artery, right? The blood supply to the this half of the palm is still reduced, because I'm applying pressure on the radial artery. But as soon as I lift off my pressure from the ulnar, the palm turns red. The color of the palm, returns back to normal. It is because of the connection between the superficial and the deep branches. Superficial and the deep branches. I told you we do something called as we do something called as arterial blood gas analysis, ABG, in which, what do I do in ABG? I actually puncture the radial artery and then I draw blood from the radial artery. Imagine, guys, for some person, the arch is not patent, right? The palmar arch is not patent. The communication between the deep and the superficial arches is not patent. Then what will happen? I'm actually puncturing one artery, meaning I'm reducing the blood supply to that particular area. If the arch is not patent, then the ulnar artery cannot take over and the blood supply will not be restored. It will result in gangrene. The entire the lateral aspect will turn gangrenous, because I've punctured the artery and the arch is not patent. That is the reason why I do modified Allen test, to make sure that the arch is actually patent and I can easily go ahead and puncture the artery. Okay. Yes. As the color returns, Allen's test is considered to be normal. I know it is a little confusing right now, but once you see the practical application of this, go and ask any of your seniors to show how Allen's test is done, or to show how ABG is done. Then you will understand. Okay. Then you will understand why this test is done. Right? If the color fails to return back to normal, then the test is considered abnormal, and it suggests that the arterial supply to the hand is not sufficient. Right? It indicates that it may not be safe to cannulate or needle the radial artery. Okay. That's it about the superficial and deep palmar arches. Let us then go to anatomical snuff box. Anatomical snuff box. Okay, again a very important topic for your theory. What is this? When you make your when you make the shape like this, you see a triangular depression here, right? When you see a triangular depression here on the where exactly? This is on the lateral side of the dorsum of the hand, right? What is this I'm pointing at? This is the dorsum of the hand. Whether it is lateral or medial, it is the lateral side. So, anatomical snuff box is a triangular depression seen on the lateral side of the dorsum of the hand, the hyperextended thumb. The hyperextended thumb. Again, what are the boundaries? Floor is formed by the scaphoid and trapezium bones. Homework for you guys. What are the carpal bones? What are the carpal bones? What is a mnemonic? She looks too pretty, try to catch her. You will tell me whether this mnemonic is from medial to lateral or lateral to medial. How many rows are there? And then you will tell me which is the last bone to ossify. You will also tell me which is the sesamoid bone out of these carpal bones. Okay, homework for you. Now, in the floor, we have scaphoid and the trapezium. In the roof, we have skin and the superficial fascia. Anterolaterally, we have the tendons of abductor pollicis longus and extensor pollicis brevis. Posteromedially, we have the extensor pollicis longus. Extensor pollicis longus. Okay. Then, so this is the location. This is the location. You can see this is the extensor pollicis longus tendon, and this is the anatomical snuff box. You can see this triangular area here. You can see beautifully the triangular area. And this is the extensor pollicis brevis tendon. This is extensor pollicis longus tendon, and here we have the anatomical snuff box. Okay, you will have to make this small line diagram here, guys. When this question is asked, just make this cutie small diagram. This is the extensor pollicis longus tendon, extensor pollicis brevis, right? It is a triangular structure. In the base, what do we have? We have scaphoid and trapezium. We have scaphoid and trapezium. Of course, we have the abductor pollicis longus tendon here. And in the contents, we'll see in the contents, what are the different structures that pass over the roof? We have the cephalic vein, and the terminal branches of the superficial radial nerve, which is lateral to medial. Look at it. This is the superficial branch of the radial nerve. This is the radial artery, and this is the cephalic vein, which is superficial, right? Radial artery, superficial branch of radial nerve, and cephalic vein. This class may be a little boring because it is all conceptual. Here I cannot make it any more interesting because it's all theory. It is there. We cannot do anything about it. We just have to learn it, right? There's no concept involved here. There is no interesting thing that is happening. I will have to teach it the way it is, okay? Then, what is the clinical importance of this? The radial artery pulsations can be felt in this space, and tenderness in the anatomical snuff box indicates the fracture of scaphoid bone. Okay, scaphoid bone is prone for avascular necrosis, which you will study in your orthopedic section. Okay, whenever they mention there is tenderness in the anatomical snuff box, think in terms of fracture of the scaphoid bone. Then cephalic vein can be used for IV cannulations, which is not so. It is used sometimes, but mostly we use the median cubital vein in the cubital fossa. Okay, I know it's very theory oriented, but it is what it is. You will have to learn it. Okay, yeah. Then the most important topic, I would say, which is something that you will have to keep reading, something that you will have to keep understanding because it has got a lot of practical implications. Okay, median cubital vein. Median cubital vein is a communicating vein between the cephalic and the basilic veins. Where is it situated? It is situated in front of the elbow joint in the cubital fossa. It starts from cephalic vein 2.5 centimeter below the elbow, and it passes upwards and medial, and it finally joins the basilic vein above the elbow. Now, the most important point is it is extremely superficial, right? It is very superficial, and it lies superficial to the deep fascia, right? It is there in the superficial fascia itself, and it is easily accessible, right? Because it is easily accessible, it is this vein that we always choose. It is this vein that we always choose for IV cannulations. Whether you go for just drawing some blood for blood test and things like that, or you want to actually cannulate and then put some IV fluids, this is the choice of vein. This is that vein we always choose, whether the patient is in shock or I just need to draw some blood. This is the vein that I always choose for cannulation. Okay. Now, what are the two veins that it is connecting? It is connecting cephalic and basilic veins. Now, it lies in front of the bicipital aponeurosis, which supports it, and it actually separates it from the brachial artery and median nerve. And it is very safe to cannulate this, guys, because I have the bicipital aponeurosis, which separates it from the artery. Now, I don't have the fear of cannulating an artery, right? If I cannulate an artery, then it is a disastrous thing, right? You never cannulate an artery unless it is some cardiovascular procedure that I'm doing. Otherwise, I never cannulate an artery unless and otherwise it is indicated, right? So this vein, median cubital vein, lies in front of the bicipital aponeurosis and it supports it, right? Even if I go a little deeper, I'm hitting the tendon. When I hit the tendon, it may cause slight discomfort to the patient, but I'm not hitting any artery or any injuring any nerve. If I injure median nerve, it'll cause carpal tunnel syndrome, or it may cause numbness in the medial lateral, three and a half fingers, right? That is why median cubital vein is that safe zone for us to go and cannulate, right? Then it communicates with brachial veins by a perforator vein that pierces through the bicipital aponeurosis. The reason why we choose this vein for cannulation is because, number one, it is very superficial, easily accessible. Number two, it has the support of the bicipital aponeurosis, which separates it from the brachial artery and the median nerve. Okay. Yes. Clinical important, it is often the largest vein in the region and is frequently used to take blood samples or giving IV injections or blood transfusion or even in cardiac catheterization, right? Even when you do, if you get a chance, go to cath lab and see how these cannulations are actually done. Whenever you get a chance to tag along with your medicine residents or with your other residents, just go to the cath lab and see how they cannulate the artery and how they cannulate the vein, how they pass the guide wire, how they take the stent and everything. It's very, very interesting. If you get a chance, go ahead, go and see in cardiac cath labs to see how exactly these procedures are done. But otherwise, also, a median cubital vein is largest vein in the region and it is used to take blood samples. Okay. Yes. Now, this is just a small table of upper limb joints that I have here. I would like to cover this in the next class along with shoulder joints, because then it will make more sense. I've just included this in this presentation itself so that you can have just go through this all these tables once, and so that you come prepared for tomorrow's class and just go through this table once, and this will really help you even in your revisions. When you're just going through the joints in one shot, you can just revise all the joints. To summarize today's topic, we first did cubital fossa, then we did brachial artery, and then in the end we did the clinical importance of having the patency of the deep and superficial palmar arches and the modified Allen's test and everything. Then the most important takeaway home message is this median cubital vein, which we use to cannulate in our regular day-to-day clinical practice. Okay. Too many applied aspects today. Number one applied aspect today is the brachial artery, which is used to record blood pressure. Second applied aspect for today is the median cubital vein that I use to cannulate. And the third is the modified Allen's test that is used to see the patency of the superficial and deep palmar arches and the communications between them. Fourth is the radial artery palpation. Where do we palpate for radial artery? Where the thumb is. Where the thumb is. Never make that mistake. Okay. And of course, anatomical snuff box is another topic. Lots of things to revise. Lots of things that we have covered in today's class. Very easy stuff. Very theory oriented. And I'm sorry if if I could not make this class any more interesting, I hope you found this class useful. Go back home and read whatever that has been taught today. Okay. And in tomorrow's class, we'll be covering all joints in one shot with a complete focus on the shoulder joint. Okay. And you can follow us across all the social media handles. And if you have any doubt, you can always reach back. And we are available on YouTube and Instagram, Facebook, as well as Telegram. And you can download our app and join the live classes. And thank you so much, guys. And I'll see you guys today eh, teaching shoulder joint. And I wish you all the very best. Keep studying. And thank you so much.